Welcome back to the Humble Healer podcast. This is episode 8. And my name is Dr. Quang Lei. I'm a board certified family physician. And today I want to talk about a topic that really very close to what I do in clinical practice, and is the overuse of antibiotics and how that can be very harmful on an individual basis as well as a population basis. And I will explain to you why, and I hope that by the end of this podcast you will think differently about the use of antibiotics and how we should be very cautious about using that for our illnesses and symptoms. So the definition of antibiotic stewardship is how to use antibiotics responsibly to maximize benefits and minimize harms. And Dr. Fleming, the scientist that invented penicillin and antibiotics, could not have anticipated the proliferation of antibiotics that would follow his discoveries, nor would he have understood the profligate and injudicious use of these agents in modern therapeutics. This is a quote, anonymous, and there are key figures from the CDC 2019 antibiotic resistant threats report, which included 35,000 plus deaths from resistant bacterial infections and over 48,000 deaths when considering Clostridium difficile infections as also a complication of antibiotic use, and over 2.8 million annual infections from antibiotic-resistant bacteria. These highly resistant bacteria can be very scary to treat, and the hospitalist and staff and the intensivists had to struggle to deal with these very nasty bugs that have come about due to the overuse of antibiotics in the society and the population. So just a little background about antibiotics and how they are overused. So the majority of antibiotics are prescribed in the outpatient setting, and 12.6 ambulatory physician office visits in the United States result in an antibiotic prescription, and 30% of these prescriptions are not indicated. CDC reported that at least 2 million people in the U.S. are infected with bacteria that are resistant to antibiotics, and that up to 23,000 deaths per year are linked to. In the United Kingdom, pediatric visits to primary care physicians for respiratory symptoms have been increasing. Along with this growing trend, at least 40% of children are being prescribed antibiotics for uncomplicated lower respiratory tract infections. A study performed in China found that 78 to 93% of respiratory infections were treated with antibiotics, and that more than 60% of overall antibiotic prescriptions were inappropriate. And there's a bigger problem in other countries where there is no regulation of antibiotic prescription, and you can get that over the counter, including the very broad spectrum antibiotics that can easily create highly resistant bacteria. The unrestricted availability of antibiotics over the counter can be life-saving for individuals residing in areas of limited access to medical care, but also promotes excessive use and development of resistance. It is important to note that antibiotic resistance is a global problem that requires collective effort to address. So to minimize the risk of antibiotic overuse, it's crucial to use antibiotics only when prescribed by a healthcare professional and to follow their instructions carefully. Appropriate use of antibiotics plays a critical role in population health, but increasing use of these agents had predictably led to the development of resistance that has the potential for producing devastating unintended consequences. Biologic diagnosis to support precise use of these agents is not always available and is often underutilized when it is available. In this circumstance, prescribers rely on empiric treatment, the treatment that based on clinical suspicion and often routinely favoring the use of broad-spectrum agents, antibiotics, and escalation of treatment if patients fail to respond to an initial drug. For example, if a child comes in with ear infection, and research have shown that most of these ear infections are viral, especially when they are very mild and are not associated with any fever in children that are over the age of 6 months. So what happened is a prescriber ordered an antibiotic, and when the child failed to respond, the mother or the father complained the patient or the child still had pain, brought the child back in, and the prescriber ordered even an even stronger antibiotic for a viral infection, which does not respond to antibiotics. So this poor child with a viral infection who should not have been treated with an antibiotic ended up with two courses of antibiotics unnecessarily. And since this child, and we'll talk more about this, has still developing immune system, allergy system, GI functions, and a very immature microbiome, were affected by two courses of antibiotics that really affected this microbiome and wiped out a lot of the friendly bacteria that are very beneficial for this child's health. So one can see how this can really have a lot of long-term consequences for this child's health in several different aspects. Unrestricted availability of antibiotics over the counter can be life-saving, but does promote excessive use, as we mentioned above. So where are most of the antibiotic and the inappropriate antibiotic prescription from? In the emergency department is frequently blamed. The CDC estimated that in 2013, and one can mention also from my research is the urgent care settings as well as primary care practice or office. And also even worse is the virtual urgent care practice since a lot of these patients are not being seen in person. So there is a tendency of overprescribing antibiotics by the treating clinicians to compensate for the lack of sometimes clinical information needed to make an assessment. So they tend to be more liberal with the use of antibiotics in these cases. There were about 850 antibiotic prescriptions prescribed per 1,000 people, or 4 prescriptions for every 5 people. There were repeat offenders, which mean that a lot of these prescriptions, some study found that 80% or 90% of these prescriptions of inappropriate antibiotics prescriptions come from about 10% of the prescribers only. So the role, as we mentioned later, is to educate these prescribers to reduce inappropriate use of antibiotics. And the vast majority of this prescribing occurred in the outpatient setting. However, it also has been estimated that at one point in time, up to 75% of adults with acute bronchitis will prescribe antibiotic, and there is no evidence to support this. And what are some of the common offenders for inappropriate antibiotics? As mentioned above, acute bronchitis used to be expected by patients and a lot of the providers, clinicians, to prescribe antibiotics. And sinusitis, otitis media, and asymptomatic bacteriuria, which means patients have bacteria in the urine that are not causing any problem, especially in non-pregnant women or patients. So in that case, you're just treating the bacteria and you're not really treating the patients. And the bacteria are not causing any problem. Just like the bacteria on our skin are not causing any problem. We should be treating that. A lot of time, emergency or urgent care physicians or primary care physicians are not comfortable with diagnostic uncertainty, as I mentioned above, especially in virtual setting where you just see them over the Zoom setting, that they tend more likely to be prescribing antibiotics in these cases because of these diagnostic uncertainty, and they may not see the effect of the overprescribing of antibiotics. However, working in this super urgent care setting that I'm in, I have seen many cases of complication of antibiotics, including patients that come in with C. diff colitis, which is a bad bacterial infection caused by the bacteria that normally are harmless, since the use of antibiotic cause widespread destruction of a lot of the friendly bacteria in our gut. This bacteria, Clostridium difficile, emerge and cause a problem, including C. diff colitis infections, which can be very severe. I also have seen allergic reaction in patients receiving antibiotic appropriately or inappropriately, and some of which can be life-threatening, and other side effects such as QT prolongation or arrhythmia that can result from the use of azithromycin, especially during the COVID pandemic. And one class of antibiotic called fluoroquinolones are notorious for causing a lot of adverse effects, especially to the elderly. And I will go over more about what other harms that antibiotics can cause, whether appropriately used or inappropriately used. In the form of antibiotic resistance, this is the main concern of antibiotic overuse. When they are used too frequently or for inappropriate reasons, bacteria can develop resistance to them. This makes it difficult to treat infections caused by these resistant bacteria, leading to more severe illnesses and increased healthcare costs. You can see how a patient with resistant bacteria had to undergo treatment with many different kinds of antibiotics, and that prolonged the hospital stay and complications even more. Disruption of gut microflora, and we mentioned that about this earlier, how antibiotics kill not only harmful bacteria but also beneficial bacteria in the gut. And the disruption of the gut microflora can lead to digestion problems such as diarrhea, nausea, abdominal pain. And if you listen to my nerve gut access podcast before, you can see that the disruption of this microbiome can cause devastating consequences to our health in certain individuals. So this is not a benign treatment with antibiotics. And not only in the gut, but also in the respiratory system, which can increase the risk of having more pneumonia or other respiratory infections. And also in the reproductive system, that's why women get yeast infection when they take antibiotics, not uncommonly, and many other complications. Disruption of microflora in other systems is also a concern, as mentioned above. By killing off beneficial bacteria, antibiotic overuse can make individuals more susceptible to other infections, including opportunistic infection that would not normally cause problem in healthy individuals. We talked about allergic reaction, which can range from mild symptoms like rash to severe anaphylaxis, which is a life-threatening infection that need to be addressed emergently. And the risk of allergic reaction increases with prolonged or repeated use of antibiotics. And development of superbugs, overuse of antibiotics can contribute to emergence of superbugs, which are resistant to multiple antibiotics, are extremely difficult to treat, and pose a significant public health threat. Some of which now we do not have antibiotics to treat, and the patients end up dying since they do not have any treatment to give them. Other health problems can be linked to an increased risk of chronic health conditions such as asthma, obesity, autoimmune disease. There is a spiraling empiricism. Empiricism means empiric treatment, treating based on clinical suspicion. And there's a fallacy in antibiotic therapy involving broader is better, broader spectrum of antibiotic is better, which is not true. Failure to respond is failure to cover, which means treating for a virus and patient not responding, give them a stronger antibiotic instead of considering the fact that it could be just a virus. More disease, more drugs, not true. Sickness requires immediate treatment, not true also. You have to investigate to see whether this is a bacterial infection that requires antibiotics. Response implies diagnosis, not correct either. You get a cold and you got Z-Pack, and Z-Pack end up on zithromycin actually has anti-inflammatory effect that can make you feel better, not necessarily because of the bacterial killing, just because the patient is running its course with a viral infection and the anti-inflammatory effect of azithromycin makes the patient feel better. Bigger disease and newer drugs and antibiotics are non-toxic. That is fallacies that need to be dispelled in the healthcare community, and a lot of trainees need to be educated about this. So what are we to do as providers in reducing inappropriate prescribing of antibiotics? We practice antibiotic stewardship. And what is antibiotic stewardship? As we mentioned, is most people, and we aim to make sure that every patient receives the optimal antibiotic treatment. This might mean antibiotic only when needed. For example, avoiding antibiotics for acute bronchitis or other conditions when they have no benefit. And if they are needed, we should provide education and intervention to get people to use the right antibiotic at the right dose and for the right duration. What do you say to patients? We are all very concerned about patient satisfaction. Unfortunately, doctors, PAs, and other providers are score on patient satisfaction for their performance or giving antibiotic to patients. A lot of times can increase patient satisfaction. We have all had interaction with a patient demanding antibiotic who leaves in a huff and is very upset. I've had an elderly female patient calling me that I'm just a kid playing doctor in her case because, I refused to give her antibiotic for her sinusitis, which mostly are caused by viral infections. Most patients don't come in demanding an antibiotic, and we may assume that is what they want. Evidence suggests that they are still satisfied, but if they don't get an antibiotic, patient is upset. It may be about something else, such as their communication expectation were not met. I have patients that communicate to me that they very appreciated the fact that I spent time explaining to them my rationale for not giving them an antibiotics, and was being done for their benefits and not because I was withholding treatment. May also present the data for harm. Most patients don't understand the difference between viruses and bacteria. There's an expert in antibiotic stewardship that explained that we need to treat 4,000 patients with an upper respiratory infection to prevent one pneumonia. And unfortunately, the number needed to harm is 4 to 20 for patients. So if we treat 4 to 20 patients, we can cause harm in one patient, which is a lot more significant than the 4,000 patients that we need to treat to prevent one pneumonia. Diarrhea can occur up to 25% of patients, with a small subset of patients developing Clostridium difficile infection, as we mentioned earlier. Yeast infection and minor allergic reactions may occur. A small number of patients may die due to anaphylaxis, which is a life-threatening allergic reaction, and acute kidney injury or Clostridium difficile. Provide positive recommendation about what the patient can do to help alleviate symptoms. A patient coming in with bronchitis, they usually, a lot of time, they cough their brain out and they cannot sleep, and their spouses cannot sleep either. Give them something to help them rest at nighttime so they can be less miserable. Give them something so that they can work during the day. Recommending something like honey and warm tea with cough drops and a piece of lemon so that they can function during the day and don't have to go out to work. Help them out so they can feel better without resorting to antibiotics. And also, it's important that we call their bronchitis a chest cold. There are studies showing that by saying that it's a chest cold, it's more convincing and persuasive to tell patients that antibiotics are not necessary. Engage the patients. And what are some of the things that we can implement right away? We try to do clean cache urine specimen, meaning that if patients we not strongly suspicious of a urinary tract infection, you try to catch a urine culture before treating with antibiotics, especially in patients without urinary symptoms like urgency or frequency or dysuria, and also use antibiogram to guide our antibiotic selection to provide more specific target to treat specific bacteria. No broad-spectrum antibiotics. What can patient do? Learn to take antibiotics only when necessary, only when prescribed by a healthcare professional for bacterial infection. Complete the full course, because if you don't, you will create resistant bacteria within your own system that will make it more difficult for any doctors or other providers to treat you in the future for the same infection if you do not complete your course of antibiotics. Do not share antibiotics because you do not know whether that's the appropriate treatment for the patients, and do not pressure healthcare providers that you see for antibiotics. Defer that decision to them. They went for years of education and training in order to tell when and when not to use antibiotics. Respect that training and don't pressure, especially an inexperienced provider that may give in to you, especially intimidating patients. Do not pressure them. Let them make the decision themselves. I hope that you find this talk helpful, and this is not only for patients, but also for healthcare providers out there. And please use it to share with your patient when you want to provide education about antibiotic overuse and why you do not prescribe antibiotics for your patients. Thank you, and look forward to have you again as my audience next time. And please provide feedback, subscribe to the channel, and hit the like button if you do like the segment, and share with friends and family. Thank you very much.